The topic I am going to cover is unravelling to the patient. And you are ready to be congratulated. But instead, when your patient starts screaming, "Doc, I hate these unwanted images that you have given me," this is not what you wanted to hear. So what is dysphotopsia? Dysphotopsia are undesired optical images associated with otherwise uncomplicated, uneventful cataract surgery. Patients are incredibly unhappy and they move from one ophthalmologist chamber to another, and when they are told that your surgery is perfect, no more. Why? Because photopsias are visual perception that arise in the absence of light stimuli, but the visual disturbance of dysphotopsia do not occur in the absence of light stimuli. In the literature, terms such as photopsia, entoptic, and photic phenomena have been used, and the term dysphotopsia was used for the first time in June 2000 by James Tester. And both surgeons and patients are unhappy, and when the surgeons tell the patient that it will go away in time, it does not always turn out to be true in 100% of the cases. Some of these patients are so upset that they have filed lawsuits against ophthalmologists and lens manufacturers. So two major categories. I'm going to cover only the part arising from the IOL edges. Edge reflections are called positive dysphotopsia and edge scotomas are called negative dysphotopsia. We wanted some desirable traits in foldable lenses that have led to undesirable optical phenomena. We wanted thin lenses to go through small incision, it acts like a mirror. We wanted square edges to decrease PCO, it causes internal reflections. We want hydrophobic IOLs because they cause less PCO, but because of low anterior curvature and high refractive index, they cause these optical phenomena. Truncation, bitruncation, all leads to mirror-like effect. So negative dysphotopsia was reported for the first time in 2000, and it is the commonest type. It is less understood, more debilitating, and it unfortunately occurs only with perfect surgeon, perfect surgery, good IOLs, and it is a sickle-shaped dark shadow or a crescent that gives the impression of a shade over the temporal peripheral region of the patient vision and has been likened to horse blinders. So why does it occur? Imagine temporal light of rays. When they strike the nasal edge of the IOL, it is reflected back. The simplest theory is that now there is no light rays to be refracted, so there is a edge scotoma. But when ray analysis was done by by Holliday, what he found was that there are three types of shadows: type 1, type 2, and type 3 shadow. Imagine from the sharp edge, light rays are reflected from the posterior surface of the IOL and the edge of the inferior edge of the IOL. So there is scotoma between this maximally refracted rays from the posterior edge and from the inferior edge, and so there is 2.5 to 3 degrees of this shadow which is not illuminated by the light rays, which causes negative dysphotopsia. So in literature, three types of causes have been listed. First is light entering eye from the temporal periphery is reflected and there is no light rays to be refracted. And some simplistic explanation given is it is just like ring scotoma in the phakic glasses of the yesteryears. So it is manifested by a dark shadow in the temporal periphery. So what are the optical factors required for negative dysphotopsia? There are primary and secondary factors. Primary is if you have a small pupil, there is more distance behind the pupil, and it has been calculated. The crystalline lens is 4 millimeter, whereas if the pseudophakic lens is less than 1 millimeter. So after removing the cataract and implanting a IOL, there is more distance between the iris and the IOL, and it has been calculated that if it is 0.06 to 1.2 for acrylic and 0.06 to 0.62 for silicone, this predisposes to development of dysphotopsia. Sharp edge design of the IOLs, functional nasal retina that extends anterior to the shadow, and the secondary factors are high refractive index of optic material which is there in hydrophobic lenses, large angle alpha, nasal location of the pupil, transparent status of the peripheral nasal capsule, and more with high plus lenses. Why this dark shadow occurs only temporally and not nasally? Because light coming in nasally is tempered by the nose, eyebrow, and cheek. And second factor is that the nasal retina may extend further anteriorly than the temporal retina. So these are some of the pictures which have been drawn by the patients, and these are the temporal dark shadows which haunt them. What is the incidence? It is said that in the immediate post-operative period it is 20%, but it decreases in the long term to about 5% by 6 months and less than 2% 2.4% in after 2 years. So that dysphotopsias can be transient. Why it occurs is it resolves in 2 weeks, and it is due to the hydration of the temporal clear corneal incision. Temporary is the one which really resolves within 6 to 12 months. I told you incidence decreases from 20% to 5%, and why it disappears is because as the peripheral nasal rim of the anterior capsule opacifies or when there is neuroadaptation. But it is the persistent variety consisting of lingering cases that annoys the patient and perplexes the surgeon. So I told you it occurs with well-centered in the back PC IOLs. It does not happen with poorly centered IOLs. I'll just take a minute, sir. It does not happen with sulcus IOLs, does not happen with AC IOLs, occurs with hydrophobic IOLs, does not occur with hydrophilic IOLs, does not occur with silicone IOLs, increases with bright light, dilate the pupil, problem resolves. Constrict the pupil, problem worsens. Since no medical therapy seems to work, surgical management may be required in some subgroup of the patients. So, and what is the surgical management? Either we can remove nasal annulus of the anterior capsule or place shoulders of the haptics of 3-piece IOL horizontally, do reverse optic capture, piggyback IOL, or there are some newer IOLs like anti-dysphotopic IOL by Mascot or Mary Tessignon. What you can do is take the patient on the slit lamp and just give yak shot to the peripheral annulus of the nasal anterior capsule, and this goes on to prove that some of these patients may be having this dysphotopsia because of the shadow of the anterior capsule nasally. So by removing that annulus, that problem resolves. By placing single piece IOL horizontally, why it resolves is because this haptic acts as the extension of the optic. So light rays may bleed through this optic haptic junction and that shadow may be illuminated. Reverse optic capture, what you do is you bring out the IOL edge in front of the anterior capsule. First you bring out the nasal edge of the IOL optic from in front of the anterior capsule, then temporal. So what it does is, again the shadow factor of the anterior capsule rim is taken care of. Piggyback IOL, how does it help is, by placing one more IOL, it decreases the distance between the iris and the IOL, and it also covers the anterior capsule. This is a newer IOL which has been made by Mascot. What it does is, it has a ridge on the optic edges into which rests the rim of the anterior capsule. So this part is, that's why it is called Mascot anti-dysphotopic IOL. Bag in the lens IOL is that instead of placing IOL in the bag is taking care of the IOL. So this IOL is supported by anterior and posterior capsule, for which we need to do both anterior and posterior capsular access, with which many of our surgeons are not very comfortable. IOL exchange is the last resort. When the problems do not resolve in 6 months, then consider IOL exchange. And what newer IOL you have to put now is, replace it with a IOL which has low refractive index, not acrylic, rounded edges, optic diameter of the lens has to be large, surface reflectivity low, and move more power to the anterior surface and less to the posterior surface. But imagine if you have already implanted this lens and patient has developed negative dysphotopsia, then what do? So precise reason why only certain patients and not 100% of the patient develop negative dysphotopsia still remains a mystery. Reverse optic capture and piggyback IOL implantation in the sulcus are the most successful approaches for negative dysphotopsia. So surgeons need to know that dysphotopsia is a real legitimate problem. Don't fool the patient by saying all is well. Yes, you can counsel that in the near future all will be well. Thank you everyone for your kind and patient hearing. So if we are able to remove these haunting images from the field of vision of these distressed souls, smile will return back to their countenance. Thank you everyone for your patient hearing. And I'll also take this opportunity for your support for the candidature for member scientific committee in the coming AIO selection. Thank you, sir.